Welcome everybody for PCC rounds. Today we have a guest, and I guess one of our own talking today. A guest because Dr. Darrell Lewis has joined PCC from, has moved, I guess kind of moved over from Halifax. Was a cornea specialist at Dalhousie and in Halifax, and still is very active with the teaching and clinic and surgical program there. He's also the director of the eye bank in Halifax. So he has multiple hats that he wears and is involved with quite a few research projects that are kind of interesting. And the reason why we're really excited is that Darrell has joined our PCC team. And so we now have 3 cornea surgeons and optometrists with interest in cornea. So 4 doctors in total here at PCC. And so I'm really glad to have Darrell present to us on something that's kind of really interesting, corneal neurotization for neurotrophic keratopathy. And so Darrell, was super pumped to have you here. Darrell, as many of you may know, did his residency at Dalhousie University, then went off to do what seemed like a really amazing fellowship in Australia. And that backdrop, maybe Darrell will tell you the story behind that backdrop, but after the fellowship training in Australia, he came back to Halifax where he had a position in the department and worked there for about 2 years, eh, Darrell?
Yeah, around 2 years.
2 years, and was also involved not only with cornea and anterior segment external disease, but also with refractive surgery, being a surgeon at LASIK MD. So super guy, multiple hats, lots of experience. So we're really happy to have you, Darrell, and look forward to your talk.
Thank you very much, Dr. Bagg. So this is Cradle Mountain in behind me here. I don't know if my head movements, you can kind of see the whole picture, but when I was in Australia for the year, it was really the only time I got to see snow. So it was great climbing Cradle Mountain a little bit in the Tasmanian winter, hanging out with wombats and that sort of thing. So I'm going to mostly talk about neurotrophic keratopathy today, and we'll talk a little bit about corneal neurotization. I don't pretend to be a world-renowned expert on this subject. I have a limited experience. I've only been in practice for a couple of years now, so maybe some of the people in the audience today know more about it than I do. And so hopefully I can give you a couple of interesting tidbits, and maybe if some people are able to share some knowledge later on, they can do that. So I don't really have any financial disclosures. I guess we'll pull up a poll just to kind of see who's in the audience today and where we're all at. So, you know, the first polling question is, do you routinely treat patients with neurotrophic keratopathy? So you can just answer really quickly, just yes, no, and we'll close this poll pretty quickly, whether or not you treat patients with neurotrophic keratopathy or not. I think we can see the results. So yeah, so 2/3 say yes, and 1/3 says yes, and 2/3 say no. Okay. And so the next question is, have you ever performed a corneal neurotization procedure? And I would think that this would be less if only 1/3 of people are actively treating neurotrophic keratopathy. And hopefully by the end, you'll understand that you're probably treating more neurotrophic keratopathy than you realize. So have you ever performed a corneal neurotization? And 90% of people say no. Okay, well, at least I have some experience more than the rest of the people. And 10% saying yes, that's pretty impressive. So, and then I guess this is mostly for that 10%. What is the, or the 90% who's not doing it right now, sorry, is what is the most significant barrier to the implementation of corneal neurotization in your practice? So what sort of barriers do you have to starting it if you are interested in doing it? Sort of only get to select one of multidisciplinary intervention, infrequent referrals, hospital overtime, or technical difficulty of the procedure. Maybe we can close that poll now. Technical difficulty, yeah, so it's a bit of a spread, and certainly multidisciplinary intervention and technical difficulty makes a whole lot of sense. Okay. So today we're going to go through neurotrophic keratopathy a little bit in its presentation, some of the anatomy that is important for it, neuroanatomy, pathophysiologic mechanisms, common causes, treatment options, and then talk about corneal neurotization, sort of an overview and surgical approaches. So there's this classic Mackey staging for neurotrophic keratopathy. And so stage 1 is inferior conjunctival staining, and this can be of the palpebral conjunctiva or the bulbar conjunctiva. And here is just showing a rose Bengal staining, which can show some devitalized cells where fluorescein might not be able to pick this up right away. And in stage 1, you might also see a decreased tear film breakup time. Neurotrophic keratopathy, often the epithelial microvilli, the corneal epithelial microvilli get damaged. And as a result, the tear film doesn't wet over the surface as well from reduced surface area and amphiphilic proteins on the microvilli surface. And so that leads to desiccated epithelium. Sometimes these are called goal spots, which you can see in the periphery usually. And then you can see a loss of a sheen on the surface of the cornea. And stage 2 is where you get a frank epithelial defect, which may develop into a persistent epithelial defect or a PED. Surrounding that area, which is usually quite ovoid in nature, you might get some loose epithelium. You might see some rolled edges, and you can develop corneal stromal edema. This is in part due to a little bit of inflammation, in part due to the loss of tight junctions on the epithelial surface, which then allows the corneal stroma to take up fluid from the tear film. And then this is like kind of a bridging of stage 2 and stage 3. So on the left-hand side, you can see this very desiccated surface it's lost the normal corneal sheen. And on the right side, you can see those very rolled edges that can occur. And even here on the right-hand panel, you're seeing a little bit of, if I can pull out my laser pointer, maybe I can't. But you're seeing a little bit of keratolysis, a little bit of stromal melting, and you get this sort of like gray ring-like filaments that you can see at the base of that ulcer. And then if you're really unfortunate, stage 3 progresses and you get keratolysis or melting, which can lead to things like hypopyon, AC reaction, and then ultimately perforation. If you're lucky and you get on top of it in stage 2, then you might develop some surface healing, which leaves you with corneal scarring and neovascularization. So what are the mechanisms that lead to neurotrophic keratopathy? Well, really it's about impaired wound healing through various mechanisms, and hypoesthesia then leads to decreased reflex tearing and decreased reflex blinking. And the epithelial cell morphology changes, as I mentioned, about the microvilli on the surface, and then you get an altered epithelial mitotic mechanism. And I just want to talk a little bit about the blink reflex because it ties into the supraorbital supratrochlear nerve and the V1 distribution and how that relates to blinking a little bit. So here's an image of a probe, electricity stimulating the supratrochlear supraorbital nerve area. And you can see that reflexive blinking occurs when a pulse is applied to the surface. And so there's clearly a reflex arc from cranial nerve 1, ophthalmic distribution, cranial nerve 1 stimulation to cause blinking to form. Okay, so there's a reflex neuro arc there. And there's something called Meyerson's sign. And this is where an individual who has Parkinson's disease cannot abolish the blinking phenomenon that goes along with tapping of the forehead. So hopefully everyone is in their room right now tapping themselves on the forehead and seeing if you can abolish your own blink reflex. So this is tapping in this area and you can see I'm not blinking. Infants, before they develop the frontal processing to abolish this reflex, and people with Parkinson's disease cannot stop that reflex from forming. And so you can very clearly see that there's this connection between V1 distribution sensation and a blink reflex. So we talk about neuroanatomy a little bit. We're really talking about the ophthalmic nerve and the V1 distribution. And my pointer's still not working, okay. Unfortunately, I can't point things out to you, but if you look at this V1 is circled up on the upper left, you can see that it's kind of broken up into the frontal nerve, which gives you the supraorbital and supratrochlear nerve, the lacrimal nerve, so innervating the lacrimal gland, which is a little bit of a complex thing, but we'll go over that. And then the nasociliary nerve, which gives off long and short ciliary branches, and the long ciliary branches are what carries afferent nerves to the cornea. This diagram's not perfect. There's a couple of little mistakes in it, but the key point here is just to show that that long ciliary nerve coming off the nasociliary nerve and innervating the cornea. And these are really acetylcholine receptor driven nerves within the cornea. And the cornea has several different types of corneal nerves, predominantly what are called A delta fibers, which are thinly myelinated nerve fibers that penetrate the corneal stroma and move centrally in a radial fashion. And then they lose their myelin as they break through Bowman's membrane. And then there are unmyelinated C-type fibers. And altogether, there's about 70% nociceptor fibers there. So this is like painful stimulus, that sort of thing, noxious stimuli. And then 20% mechanical for the actual deformation of the cornea itself. So this is like a proprioceptive mechanism. And then 10% is sort of thermal. So these are, to be able to feel cold sensations. And often things like proparacaine and tetracaine work well on the nociceptor and mechanical receptors. They don't actually work that well on the cold receptors. And so that's why sometimes patients, even though they're anesthetized, will still feel a cold sensation. And so this is just a reminder about the organization topology of the nerve. So you've got fibers entering through the stroma, then they move in a radial fashion. And if you look in the upper right panel, you can see that there are some that perforate through Bowman's sort of peripherally, mid-peripherally, and then centrally. And they create this plexus of nerves that you can see in the lower left panel there. This is an in vitro staining of subbasal nerve fiber plexus. So the nerve fibers actually come all the way up through the epithelium, not right onto the surface, but very close to the surface. And so this makes this organ, the cornea, very, very sensitive. There's usually around 44 nerve trunks, and the cornea is 300 to 400 times more sensitive than skin. In that lower right-hand panel, just to remind us about how epithelium grows, this is what's called a confetti mouse. So this is like DNA-altered mouse that then grows different colored corneal epithelium. And you can see that the epithelium migrates from the limbus centrally in a radial fashion, where right at the very center of the cornea, you get this confluence of all these radial spokes from the periphery. And you can see both the subbasal nerve fiber plexus and the epithelium meet in the center, and you often get a whorled pattern when you have neurotrophic keratopathy or limbal stem cell deficiency. And so going back to the blink reflex thing, we're talking about the supraorbital nerve and V1 distribution. It comes back into the brain in an area called the ipsilateral trigeminal principal sensory nucleus. And then interneurons pass from that nucleus down to cranial nerve 7. And then from cranial nerve 7, you get a blink reflex. So this is all mediated by interneurons within the brainstem itself. And that reflex arc can be abolished through several mechanisms, one of which is the loss of corneal sensation, or the loss of sensation in the V1 distribution. And the other is like an efferent cranial nerve 7 pathway problem. And you can see on the right-hand side here, this person has a Bell's palsy and a facial nerve paralysis. And you can see the lower lid is drooping down, creating a paralytic ectropion. And this really creates a very dangerous situation where someone has a lack of sensation on the surface, but also has very bad lagophthalmos and exposure keratopathy. So mechanisms, impaired wound healing, like we said, is really the key here. It's important to realize that nerves release a number of growth factors. So substance P and acetylcholine are probably two of the main cytokines that have been studied. And especially acetylcholine increases nuclear cGMP, and that creates epithelial cell mitosis. And so if you have a decrease in acetylcholine from a decrease in nerve fibers, then you get decreased epithelial mitosis. There's lots of other neuropeptides that are released, and I kind of listed a whole bunch of them there. Brain natriuretic peptide and serotonin, beta endorphin, all of these things are being studied right now to see if there's any therapeutic targets for neurotrophic keratopathy. But there's this big interplay between the nerves and what they release and the epithelial cells and what they release. And so the epithelial cells are actually very important for the maintenance of the nerves themselves. So you have this situation where the epithelium is dependent on the nerves and the nerves are dependent on the epithelium, because the epithelium releases nerve growth factor, and nerve growth factor is very important for the survival and maturation of the corneal nerves. And again, epithelial cells obviously release many more things than just nerve growth factor, and I've listed some of them there. Add further to this the fact that the tears contain things like substance P, which is being produced by the lacrimal gland itself, as well as insulin-like growth factor 1, which we'll talk about a little bit later. So what are some of the most common causes of neurotrophic keratopathy? So study 46 eyes, because it's not that common of a problem to have severe neurotrophic keratopathy. About 30% from diabetes, 25% maybe from HSV, neurologic sequelae about 20%, iatrogenic 15%, and herpes zoster ophthalmicus another 13%. In another study of 68 eyes, you can see that diabetes is again about 30%. HSV about 30%, previous surgery, so this might fall under like an iatrogenic category, is like penetrating keratoplasty, which obviously severs the corneal nerves, and that was 17% in that series. So neurosurgical, 10%, 10% systemic chemotherapy, and then 7% trauma, and that trauma includes things like chemical injuries and burns. So we can kind of break it down into a flow chart, so you can see systemic diseases, obviously diabetes being one of the most major ones. And this is really from advanced glycosylation products and damage to the corneal nerves as a result. Leprosy and then congenital diseases. So there are several congenital diseases which are very rare, things like Riley-Day syndrome, Mobius syndrome, Goldenhar syndrome, and congenital corneal anesthesia. Under neurologic diseases, we have things like multiple sclerosis, which is not uncommon. Neoplasms, aneurysms, especially of the internal carotid artery compressing Meckel's cave, where the trigeminal or Gasserian ganglion sits. And then neurosurgical causes, which we'll talk more about. Orbital diseases, so if you have a large orbital tumor that needs to be resected, then you may end up resecting some of those long ciliary nerves, and as a result damaging corneal nerves in the process. And then infectious etiologies, obviously HSV and VZV, leading to what we have termed classically a metaherpetic ulcer and neurotrophic keratopathy. We've already alluded to chemical injuries. Chronic contact lens use can also lead to a limbal stem cell deficiency and have overlapping phenotypes. And then ocular surgery, we already mentioned penetrating keratoplasty, but certainly an aggressive panretinal photocoagulation can damage the long ciliary nerves, and as can cyclophotocoagulation for glaucoma. Certain corneal dystrophies, and then topical anesthetic abuse, which is a very unfortunate condition. All of these things lead to impairment of the trigeminal ganglion, the trigeminal corneal innervation, and then leads to some of the issues that we talked about, poor tear film and blink rate, spontaneous breakdown of the corneal surface. So let's talk a little bit about trigeminal neuralgia, because it's important for the case that I'm going to show you. So trigeminal neuralgia is mostly an idiopathic condition where somebody gets a very sharp sort of burning sensation in their face. And most of the time it's elicited by touching in a certain area. The classic one is a man shaving on his face or neck, and that leads to a trigeminal distribution, V1, V2, V3, burning and sharp pain. Often they can have a baseline underlying pain as well that's more sort of just like an ache in their face. It's important to know as an ophthalmologist or an optometrist that if you have facial weakness or facial hypoesthesia on one side, concomitant with the trigeminal neuralgia, they really need MRI neuroimaging at that point to look for a structural lesion. And so that's a key pearl, is like, let's say someone's coming in with trigeminal neuralgia, but they have something else as well, decrease in corneal sensation, decrease in V1 distribution sensation, or facial weakness, they need to have neuroimaging. And if you do neuroimaging in 15% of those cases, you're going to find like a cerebral pontine angle tumor or an MS plaque. And obviously a CP angle tumor may need treatment, whether that's resection or radiotherapy. So because trigeminal neuralgia is most often essential or idiopathic, the typical treatment is anticonvulsants, carbamazepine, lamotrigine, that sort of thing. But cases that are refractory to anticonvulsants will go on to have surgery or radiotherapy. And for a long time, the most common treatments have been percutaneous radiofrequency ablation. So this is like a rhizotomy. And this is where a probe is passed into the Meckel's cave, where the trigeminal ganglion sits, and it actually destroys, all of the distribution of V1, V2, and V3. You can do the same thing by passing a balloon into Meckel's cave and then pumping the balloon up to a very high pressure, basically causing an ischemic necrosis of the Gasserian ganglion, the trigeminal ganglion in Meckel's cave. And then you can also do something called glycerol rhizolysis, which is essentially destroying the trigeminal ganglion in the same way. And then there's gamma knife radiotherapy, and then the last but not least is sort of an open decompression. If you think that there's an artery that's compressing the nerve, then open decompression may be the way to go, but there's a high mortality rate, about 0.5%. And with doing these things, corneal hypoesthesia, different literature suggests that you can end up with a corneal hypoesthesia or neurotrophic keratopathy in anywhere from 4% up to 35% of patients. I just want to touch on neoplasms a little bit, because I think there's often the thought in our minds that a lot of the time it's a vestibular schwannoma that causes a cranial nerve 5 pathology, and that's really not that true. Vestibular schwannomas are very, very common, especially in the setting of something like neurofibromatosis type 2. And they amount to about 8% of all intracranial tumors, but only about 2% of the vestibular schwannomas will get large enough to actually cause cranial nerve 5 or cranial nerve 7 pathology. And so really the most common presentation of an acoustic neuroma is just hearing loss and tinnitus, vertigo, that sort of thing. A trigeminal schwannoma is not the same entity as an acoustic neuroma, and a trigeminal schwannoma is much more rare, but of course would lead to damage to the trigeminal nerve, and as a result you can have corneal anesthesia as a result. So on examination, it's very important that you measure the skin sensation in cranial nerves, cranial nerve 5 in V1, V2, and V3, and this is to light touch as well as 2-point discrimination and pinprick. So each of those should be tested independently. And then obviously, if you elicit with your touching or something like that, facial nerve pain or trigeminal neuralgia, then that's an important finding. Cranial nerve 5 provides the innervation for motor innervation for mastication, and so you should check if you're suspecting corneal anesthesia. Test the strength of mastication bilaterally just to make sure that it's equal and symmetric. You want to test hearing in a gross way, and if you find that it's decreased, obviously you need to refer on to an otolaryngologist. You're going to be looking for facial asymmetry, lag ophthalmos, and incomplete blink, as well as anisocoria, because sometimes parasympathetic innervation to the lacrimal gland courses along the internal carotid artery, and you can get a Horner's type syndrome that can come along with corneal anesthesia. When you're looking at the eye itself, you want to be looking at tear film breakup time, tear meniscus height, and Schirmer's. This will tell you how much the lacrimal gland is functioning. And then you're going to look at surface staining. If you have lissamine green, great. In Canada, it's very hard to get lissamine green right now. You kind of have to smuggle it over the border from the United States in your suitcase. But some places will still have rose bengal, which is obviously burns and stings, but can highlight staining of the palpebral or bulbar conjunctiva a little bit better than fluorescein can. And then really the gold standard for corneal sensation is Cochet-Bonnet aesthesiometry, and this is just a monofilament of nylon that you can adjust the length of. And a similar thing is used for diabetic foot, touching the bottom of the foot to see when the patient can feel something. And then obviously you want to look at the fundus, because the long ciliary nerves emanate in the 3 and 9 o'clock position. And I've just put in sort of like a very aggressive panretinal photocoagulation. And you can see here that easily this PRP could damage the long ciliary nerves and lead to a neurotrophic keratopathy. There is a non-contact aesthesiometer called a Belmonte, which essentially uses some CO2 directed towards the cornea, as well as some cold air, and in a non-contact way can tell you something about the sensation. You can also do an in vivo confocal microscopy, and this can tell you something about the subbasal nerve plexus, or how dense all those corneal nerves are right underneath the epithelium. And so in the upper left panel is like a normal subbasal nerve plexus. And then as we're going across B, C, and D, we're getting worse and worse corneal neurotrophia. And it's been correlated with the length of diabetes, type 2 and type 1, this sort of loss over time of the density and branching of the subbasal nerve plexus. So treatment options: if there's no epithelial defect, then you really just want to support the epithelium as much as is possible, which means switching to preservative-free drops whenever you can, avoiding glaucoma drops where possible, switching to or using ointments. to help desiccation of the surface. And then conventional dry eye treatment, including things like cyclosporin and lifitegrast. And then you can do things like punctal occlusion as well in order to keep the eye nice and wet and the epithelium supported. Once you get into the point where you have an epithelial defect, then you need to do the same things as above, support the epithelium, but you also have to really worry about reducing exposure and preventing infection. And so there's lots of different ways of supporting the epithelium and reducing exposure. You can use the lyophilized amniotic membrane, which is this thin wafer-like amniotic membrane, which is freeze-dried or lyophilized, and it comes in a package where you can just open it up in the clinic space, and you can pop it onto the surface right at the slit lamp. It's very thin, so it doesn't last very long, and it's kind of expensive, usually around $800 Canadian, but it can help with persistent epithelial defect healing. And then you can give trophic tear supplements, and this can be things like serum tears, and I'll talk a little bit more about what the other options are for trophic tear supplements. And then you really want to reduce exposure, so you can do this with a tarsorrhaphy. If there's an ectropion, like I showed you with a paralytic ectropion earlier, then you can do an ectropion repair. If there's lag ophthalmos related to incomplete blink, then you may be able to put a lid weight in, platinum or gold, in order to help with that. You can also do a chemical-induced ptosis, and so this is Botox put in through the superior eyelid crease into the levator, and that with about 15 units can drop the upper lid for 5 to 8 weeks, and that can really give you a lot of decrease in exposure while allowing the patient to put drops in and really help. And then scleral contact lenses or bandage contact lens. The scleral contact lens we can talk about a little bit more. And then obviously there's a break in the epithelial surface, so they're at risk for infection and they need to be on antibiotic prophylaxis. When you have an epithelial defect with keratolysis, and this would be like a melt, then you want to support the epithelium, reduce exposure, prevent infection, but now you're really worried that you're going to be preventing perforation and further stromal loss. And so here you would introduce something like a sutured amniotic membrane, a conjunctival flap, which depending on what the visual potential is, can be either a rotational partial conjunctival flap or even a Gunderson total conjunctival flap if there's very limited visual potential. And you want to introduce anticollagenases somewhere along the way here. These are anti-matrix metalloproteinases like doxycycline or tetracyclines. If there's a perforation, you can place some cyanoacrylate glue, or sometimes I'll even place cyanoacrylate glue ahead of time if I think that there's an impending perforation and I really want to quiet the eye down before going on to a lamellar transplant. And then last but not least, the lamellar keratoplasty. And then somewhere along the way, we have to fit corneal neurotization into our pathway, and we can talk about that a little bit more. So what are some trophic tear supplements? So serum tears formulated to 20 to 50%. Some people have even used 100%. The serum tears includes things like epidermal growth factor, vitamin A, insulin-like growth factor 1, fibronectin, and transforming growth factor beta. So epidermal growth factor promotes epithelial mitosis and cell division. Vitamin A inhibits the corneal epithelium undergoing a metaplastic reaction. And insulin-like growth factor also promotes the differentiation and migration of the corneal and epithelial cells. Fibronectin helps the epithelial cells stick down to Bowman's membrane or the underlying stroma. And then transforming growth factor beta is something that's kind of interesting. It has some immunomodulatory properties. And most of the time, 20% is chosen because that mimics the natural tears, the amount of transforming growth factor beta that's in them. There's some thought that if you go above 20%, there's more TGF beta than there would be in the natural tear film, and that can be actually pro-inflammatory. So many people will stick to around 20%. And then there are options that some people have suggested are better than just simple serum tears. And that's like you could get platelet-rich plasma, and that can either be allogenic or autologous. And it's just really a different way of preparing the serum tears where the platelets are not pulled off with the supernatant right away. And that leads to more growth factors within the solution. Some people have used like amniotic cord blood. And then another option is to use a finger prick autologous blood where somebody uses the same sort of finger prick mechanism that they would for testing their glucose, say in a diabetic, but they actually put a drop of blood directly onto the surface of the eye. We do have a commercial preparation of recombinant nerve growth factor. This is extremely expensive. It needs to be used 6 times a day, and it costs around $13,000 US for an 8-week course. So that may limit use, especially within Canada, where insurance companies don't cover it as well as they do down in the States. And then there's some new things on the market. This is always a rapidly developing situation. There's phase 2 trials ongoing of something called ST266, which is essentially an amniotic membrane derived solution of growth factors. And I reached out to Marianne Price, and she said that they were actually part of the clinical trial for this, the phase 2 trial. And she said they've enrolled 1 or 2 patients and had some reasonable results. So maybe down the line, we'll have access to this. Because that's a proprietary formulation, some people have actually taken amniotic membrane, chopped it up into little pieces, and then put it into a solution, kind of churned it all up so that it becomes like a slush, and then filter that and apply it to the eye. And then pilocarpine, we said that acetylcholine is good for creating cell mitosis. And so there's some thought that maybe increasing acetylcholine on the surface leads to increased tear production, more wettability of the surface, maybe some increased cell growth. And so you just have to be very careful, because pilocarpine in the acute setting has been associated with graft rejection. So I wouldn't want to do this in somebody who's just had a penetrating keratoplasty, but someone who has never had a penetrating keratoplasty, a short course of pilocarpine may help. And this is something that I have started doing recently. I've got one patient that's actively using finger prick autologous blood. In Halifax, it's very difficult to get autologous serum tears. Patients actually have to drive all the way to Moncton to get it done. And so essentially this gentleman's a diabetic, and every time he takes his blood glucose, he puts a drop of blood into his eye. I'll keep you posted on whether or not that's working very well or not, but I'm sort of running out of options with him. And so that's what he's doing right now is finger prick blood. Sort of hot off the press, just released this year, is looking again at topical insulin for neurotrophic keratopathy. And so this is essentially 1 international unit per ml of regular insulin in kind of like an artificial tear supplement. And they've seen some success with that. There's a group in Canada that's trying to look at creating a trial for insulin eye drops. This is just to show you what the lyophilized amniotic membrane looks like, and the sutured kind of looks like this gelatinous kind of material that you stretch and then suture onto the surface. And then scleral lenses, they're a large diameter, they vault over top the cornea. And the nice part is that there's a well of fluid, so you can put therapeutic agents into the well of fluid. So this would be like if someone has serum tears, they could easily put the serum tears into the well of the contact lens and then apply it. They can also put in things like non-preserved Vigamox. So if they have an epithelial defect, it can provide the antibiotic prophylaxis as well as some growth factors within the scleral lens itself. So let's talk about a case. It's a 60-year-old gentleman who was referred to me with blurry vision in his left eye and then recurrent redness. Didn't really complain about irritation at all because he had a neurotrophic cornea. His past medical history, he had refractory trigeminal neuralgia in the past, and he had bilateral rhizotomies, or severing of the trigeminal nerve, about 20 years prior. And his past ocular history was significant for a prior epithelial defect and corneal ulcer in his left eye, which was pretty mild. He wasn't on any medications, and he was using Hylo gel every 2 hours while awake, as well as cyclosporin eye drops. His vision was quite good in the left eye, still 20/30. His conjunctiva did have some inferior bulbar conjunctival staining. There was some mild punctate epithelial erosion on the corneal surface, some inferior pannus, and a very mild scar. When we did the Cochet-Bonnet aesthesiometry, he had 60 millimeters, so full monofilament length in the right eye. And he was down to 5 millimeters, or 0.5 centimeters in the left eye, which is, he still had some sensation, but it was nowhere near as what it was in his right eye. Now, interesting that he had bilateral rhizotomies, and so his corneal sensation on the right side was quite normal, but his light touch and 2-point discrimination was decreased on the V1 distribution in both the right and left sides. So the trigeminal nerve was not totally normal on his right side, and he had quite significant hypoesthesia of the left cornea. So we tried large diameter contact lenses because, his surface was not completely normal. He sort of had that Mackie grade 1 corneal neuropathy. And so I tried punctal occlusion in him and a bunch of other things, and nothing was seeming to like really work. He was still getting some blurry vision, some desiccation of the surface, some redness, and he really wanted a more permanent solution. He was looking really for a cure. And so we did a corneal neurotization on him, and I'll show you a video of that. Corneal neurotization was introduced by Terzis et al. In 2009, where they described 6 patients where they did a direct neurotization. So this means that they took, dissected out the supratrochlear or supraorbital nerve from the contralateral side, which you know, that you need to have normal sensation on the other side. Unlike our patient, many patients do have normal sensation on the opposite side to the anesthetic cornea. And so this requires a big incision called a bicoronal flap through the forehead, which is, you know, a little bit of a difficult incision, and it can lead to hair loss as well as hematoma on the face, that sort of problem. But essentially, you create a bicoronal flap and then dissect out these nerves and then transpose them, tunnel them over the nasal bridge onto the conjunctiva and into the cornea. Okay, so this was the original way that this was done back in 2009. And people have tried to work to do other things since then. And many groups have come up with this, what they call minimally invasive corneal neurotization. It'll just highlight, you know, this study that was recently published by Joe Catapano, which is actually someone that I did medical school with at the University of Ottawa. And he did a PhD in this area working with Greg Warshel and Dr. Asamali in Toronto. And so they've really done a lot of work on this and probably are the leading kind of group in Canada right now in corneal neurotization. And by and large, they've been using sural nerve grafts. So sural nerve is taken from the backside of the leg in the calf area through usually a small incision with a nerve harvester. And you can see on the right-hand side here is the distribution of the sensation. So it comes down sort of the back of the calf and the lateral dorsal and ventral surface of the foot. And so most people who have had a sural nerve graft harvest or a sural nerve biopsy will have some loss of sensation in the bottom and lateral part of their foot. So what happens then is that sural nerve is connected to the supratrochlear nerve on the opposite side in what's called an end-to-end coaptation. Essentially, you cut the supraorbital or supratrochlear nerve on the contralateral side, and then you tunnel the nerve from the affected eye over to that nerve and suture them together. Again, hot off the press, just December of 2020, so only a few days away. This has been recently published online, sort of ahead of print. 26 eyes directly comparing a direct corneal neurotization, so simply taking the supratrochlear supraorbital nerve from one side and rotating it down, connecting it to the cornea on the other side, versus taking that sural nerve graft, making that incision, and then tunneling across sort of in an indirect fashion. And what they found essentially is that both options were exactly the same at 1 year. And what's interesting is that they found out of all of their 26 eyes that all patients had resolution of their neurotrophic keratopathy, so quite a good success rate. And all patients via in vivo confocal microscopy showed increase in the subbasal nerve fiber plexus. So from an anatomy perspective and a physiology perspective, they all did very, very well. What's interesting to look at, though, is what the esthesiometry did, what the actual corneal sensation did over time. And so at baseline, you can see 4 millimeters in the direct corneal neurotization group on the left column there, and in the indirect group, 2.5. And that increased to about 2 centimeters in the direct group and about 2 centimeters in the indirect group at 1 year. But you can see that if you look at the ranges that are in the brackets right beside that, it goes from like 0 to 60, and it goes from 0 to 45. So there are patients that while from a physiologic perspective, their neurotrophic keratopathy resolves, they may not actually get sensation back. It's a small percentage that never get any sensation back, but the procedure can be a success despite of not having sensation. And just to talk about the sural nerve graft, this is sort of some of the problems. Like 90% of people will have some sensory deficits. Some people have an impact on their quality of life, and they'll have sensory symptoms. So when they're walking heavily or running, they might get some allodynia or neuropathic pain on the bottom or lateral side of their foot. And so this has led to some people trying to look for alternatives that were not sural nerve based. And there's also one significant complication of sural nerve grafts is because it's in the backside of the calf, it can lead to deep vein thromboses, which can have kind of devastating consequences if you get embolism from the deep vein thrombosis. So one alternative that was looked at is the great auricular nerve. It's often hard to harvest a very long segment. The sural nerve you can easily get 15 centimeters out of, but the great auricular nerve, you might only be able to get 7 or 8 centimeters out of. And while that's often far enough to kind of get that 7 or 8 centimeters across, it is helpful to have a longer nerve graft in some settings. And some people have tried with allogenic nerve grafts from cadaveric sources, and that's not worked very well. People have also looked at alternative innervations. So like in our gentleman, he's got problems on both sides where, his right side, his V1 distribution is not totally normal. So you don't want to do a direct innervation, and you really don't want to do an indirect innervation using that V1 distribution because it's not normal. And so what we have to look for then is, well, what are the other options for corneal innervation? And down at the Massachusetts Eye and Ear Hospital, Robert Pineda and Nate Jowett have been using that great auricular nerve down in here and then indirectly connecting that up to the eye from an inferior approach. And in fact, that's what we did on our patient. Now, we didn't want to use a sural nerve graft because of the comorbidities. And so this is actually the first time that anyone has ever reported using what's called the lateral antibrachialcutaneous nerve, which is a nerve that's in the forearm. And this is the sensory distribution here that gets sacrificed. So it doesn't really affect the sensation in the hand. It only really affects the sensation on a portion of the forearm, and that tends to decrease over time. Let's talk about a nerve anatomy a little bit. All of the nerves have what's called a perineurium, sort of like a more robust outer casing. And then deep inside, you have endoneurium, which wraps individual fascicles. And so when we do corneal neurotization, what we're trying to do is actually split open and remove the nerve's epineuron, and then separate it out into individual fascicles without damaging the axons, which are embedded within each individual perineurium. It's kind of confusing, but essentially we want to split it up into several pieces. So I'll just show you a video, and that's really the end of my talk.
An incision is planned out over top of the great auricular nerve, 6.5 centimeters below the tragus. We planned out a lazy S incision on the forearm using the cephalic vein for a marker of the lateral antibrachialcutaneous nerve, which is dissected out from the antebrachial fossa down to the distal end of the forearm. A total of 17 centimeters was harvested for this procedure. We then dissected out the great auricular nerve and developed a tunnel and a supraspinatus layer to the corner of the eye. Westcott scissors were then used to make an incision through the inferior fornix over top of the Metzenbaum scissors, and the Penrose drain was then passed through the tunnel. We then inserted the lateral antibrachialcutaneous nerve into the Penrose drain, passing it through the tunnel, which you can see here. A conjunctival peritomy is performed with Westcott scissors in the inferior limbus, and this incision is then continued down to meet up with the inferior lateral fornix incision. The epineurium of the lateral antibrachialcutaneous nerve is then stripped off and individual fascicles are dissected out. Corneoscleral tunnels are then performed. We used a total of 4 tunnels around the inferior 180 degrees of the cornea, and the individual fascicles were then placed within these tunnels. Artese glue is then applied over top of the sclera and the nerve, and the conjunctival flap is reopposed. The incision is then closed using an atovicral suture. The great auricular nerve is divided with the proximal end clipped, and then the lateral antibrachialcutaneous nerve is brought in. The ends are freshened and re-approximated. End-to-end coaptation is then performed using a 9/0 nylon suture. Thanks for watching.
So that's my brother, who's a head and neck surgeon in Hamilton now. We did that case together when he was a fellow here at Dalhousie University. I'm sure that some people have questions, and I think I'm getting close to running overtime, so I would like to open it up to questions now.
Awesome. Thank you very much, Darrell. That's pretty cool. The very nice overview of something that we kind of see fairly often in cornea practices, but it's a nice overview of the various etiologies and treatment plans. And the video looked really nice. So I was curious, how did the patient do afterwards?
Yeah, so he definitely has had an increase in sensation. He's up to about 15 millimeters right now. And he's very happy because he feels that his eye doesn't get as red anymore. When we did in vivo confocal microscopy, he actually had a fairly robust subbasal nerve plexus to begin with. So that hasn't really changed much compared to his contralateral side. And the biggest problem that we got into with him, he's experienced a little bit of allodynia, and the great auricular nerve provides sensation sort of in this distribution on the back of the angle of the mandible and up to the pinna. And so he's got this sort of pinna neuropathic pain now that he's having. Also, you know, it was my first neurotization case, and I'm sure there's people out there who have done many, many more than I have. But one thing I found was I didn't leave enough of the nerve resting in the inferior fornix to give full ocular motility. And so he actually has a little bit of a leash phenomenon, which is lessened over time. But when he essentially looks like up and away from that infratemporal position, if he looks up into the left, then he gets a leash phenomenon where the globe actually, his motility is restricted a little bit, and he gets a little bit of diplopia and superinfraduction. So, you know, learning point for me, and maybe that's a learning point for other people who might be starting to do this, is to leave a little bit more nerve than you think you need. You know, either if you're coming in from a nasal approach or an infratemporal approach. And
then your tunnel passage that you did into the cornea, how long is it, and how far into the cornea do you go?
Yeah, so there's some literature coming out now that when people first started doing this, they just would leave the fascicles draped in and around the limbus. They weren't actually making pockets, but there's some literature suggesting now that the pockets actually make a difference, because what happens is when you make a pocket, you're actually getting into the corneal lamellae, and you're getting that fascicle of the nerve graft already into position where it's going to be able to track through a lamella well. Normally you've got like 44 trunks that enter into the cornea, and here you really only have 4. So it's important that they are directed in the appropriate way. Usually I was just, you know, getting in about ½ millimeter past the limbus kind of thing with that crescent blade. I don't think there's any exact length of tunnel that you need. I think it's just important that you get the nerve as far tucked into corneal lamellae as possible.
Okay. Now we have a question from Maya. Great presentation. What did you anastomose the distal end of the graft to?
The distal end of the graft goes to the distal, the proximal end of the great auricular nerve. So it's actually, the great auricular nerve is a sensory nerve for this small distribution on the face. And it has roughly the same number of axons as the supraorbital nerve, which makes it, you know, a good candidate for neurotization. And you know, that means you lose the sensation in this area, but then that C2, C3 innervation coming up recurrently from the cervical sensation is then now actually providing the sensation to the eye. And so what can often happen is people who have a supraorbital or supratrochlear, either direct or indirect corneal neurotization, for the first little while, actually, they put an eye drop in, they may actually feel it on their forehead up here. And 6 months to a year later, they'll start to localize it more towards the eye. And so the same sort of thing probably happens when you're using the great auricular nerve as the sensory root. Probably sensation from the eye is actually perceived down in this distribution, and then through neuroplasticity over time, the brain somehow realizes that that's actually on the eye.
Okay, so for this procedure to take place, for those in the audience that may be thinking of doing it, who are the critical team members that you need to get this procedure done?
Yeah, I mean, I don't think there's very many ophthalmologists that are comfortable harvesting a sural nerve graft or a lateral antibrachialcutaneous nerve graft Essentially, I mean, if you were a solo person who was maybe oculoplastics, you might feel comfortable doing a coronal flap, a bicoronal flap incision up here, and then dissecting out the supratrochlear or supraorbital nerve. But most of the time, it's a multidisciplinary approach with either plastic surgery or otolaryngology, head and neck surgery, or facial reconstruction through ENT or plastics, who then help you with the nerve graft harvesting, the isolation of the supraorbital and supratrochlear nerve, you know, bisecting the supratrochlear or supraorbital nerve, and then doing the end-to-end coaptation or the suturing of the nerve grafts together. And then it's usually a cornea specialist that then does the corneal work, separating out the fascicles, tunneling it through the conjunctiva and into the cornea.
Okay. You mentioned something about the platelet-rich plasma. So, you know, for those people who are using serum tears, how is the PRP drops different? And do you find a role in a kind of regular cornea practice for these drops to be used?
I have absolutely no experience with platelet-rich plasma. I have a hard time getting autologous serum tears at all out on the East Coast. I'm not sure if you have a different experience in Ottawa, but it's very hard sometimes to find a compounding pharmacy that's willing to take the blood and work with it. And there's a lot of regulatory hurdles to jump through that go along with it. So, you know, autologous serum tears can be made up. How platelet-rich plasma is prepared differently. It's part of the process of the preparation more so than anything else.
Okay, cool. Yeah, I've not used it either, but there's more and more work being done, and even some in-office solutions for this. So something to keep our eyes on in terms of.
There's no regulatory requirements on ophthalmologists. So if there wasn't an endeavoring ophthalmologist who was really keen on doing it, you could technically do the blood draws yourself and spin the blood down yourself, take off the supernatant, dilute it, and then they get frozen. Usually people get around a 3-month supply, and you have to package them in individual little tubes. So it's a fairly labor-intensive process, and that's why most single ophthalmology centers don't take it on themselves.
The company Salient has apparently, I know they had some product that they were showing me a few months back that may be promising. So we'll see what that shows. Any other questions from the audience? Anybody? Questions from here? And Darrell, so what are you most excited about in terms of the future of these patients who have corneal neuropathies? Is it the surgical part? Is it the medications? What are you kind of looking forward to?
Well, I think that it's a really nice, it can be a really nice surgical option. Obviously there's donor site morbidity, but I think that, you know, this has only been around really since 2008, 2009, you know, very, very rare that anyone was doing it at all before that. And so I think it's really in its infancy, and I think we are going to see things like more minimally invasive ways of harvesting nerves. I mean, this gentleman has a very large incision on his forearm. So I'm excited to see that this gets used more often, and hopefully, you know, we maybe develop some more endoscopic approaches. Some people are looking at endoscopic approaches for isolating the supratrochlear nerve or the supraorbital nerve to do their end-to-end coaptation with. So that if it gets to be more and more minimally invasive, then I think you have a reasonably good, I wouldn't say purely a cure, because it's you know, the eye's never going to be completely normal in this neurotrophic situation, but I think there's a really good chance that in the future we've got a good enough technology and surgical procedure that people can have this a lot earlier in the process, and then not go on to have, you know, perforations and bad corneal scarring. Hopefully we can start doing it when people still have good vision and can retain that good vision.
And are there any contraindications or patient characteristics that you would say this patient is not a good candidate for neurotization?
Yeah, definitely. I mean, if you look at the major series, most of them are either congenital neurotrophic corneas, or they're surgical in some way. We're just sort of only the beginning stages of trying to treat people with really bad diabetes, because they don't heal well and they don't tend to, their nerves don't tend to regrow well So the people who have really bad diabetes don't tend to do as well. And there's only a few series that have looked at doing it in things like HSV and VZV. Certainly in HSV, you could create a reactivation on the contralateral side, because if you've connected this eye that, HSV tends to recur monocularly, not binocularly, thank goodness, and it does happen binocularly, but mostly monocular. And so if you've got this eye that has HSV, and then you connect a nerve that goes into the trigeminal ganglion on the other side, we know that that HSV can easily track back into the contralateral normal eye Gasserian ganglion, and then it's resident there and can reactivate. And so heaven forbid you gave somebody bilateral HSV as a result of your neurotization procedure.
Right. Another question, do you think this procedure would be useful for patients showing signs of early limbal stem cell failure and neurotrophic cornea?
That's a good question. I mean, I think that limbal stem cell deficiency, definitely could be a manifestation of neurotrophic keratopathy, because you've got all these epithelial growth factors being secreted, and we know that people who are getting recombinant nerve growth factor, their limbal stem cell picture actually significantly improves. And so I think there's probably a very good role for neurotization procedure in somebody who's sort of teetering on their limbal stem cell deficiency perspective.
Okay, awesome. Well, Darrell, it's almost 6 o'clock. I just want to say thank you so much for this really insightful presentation. We'll look forward to maybe getting some of the oculoplastics people or ENT people kind of involved maybe in Toronto and in Ottawa here one day. So thanks for your presentation. Have a great evening. Be well, stay well, and we'll see you back in the new year.
Sounds good. Thanks for the opportunity, and I hope I didn't put anyone to sleep with neuroanatomy. I know it can be tough.
It was great. Thank you so much.
Okay, take care, everyone.
Okay, bye.